Coronavirus disease 2019. COVID-19 is a contagious disease caused by a virus. The severe acute respiratory syndrome coronavirus 2, SARS-CoV-2. The first known case was identified in Wuhan, China, in December 2019. The disease spread worldwide, leading to the COVID-19 pandemic. Symptoms of COVID-19 are variable, but often include fever, cough, headache, fatigue, breathing difficulties, loss of smell, and loss of taste. Symptoms may begin 1 to 14 days after exposure to the virus. At least a third of people who are infected do not develop noticeable symptoms. Of those people who develop symptoms noticeable enough to be classed as patients, most, 81%, develop mild to moderate symptoms, up to mild pneumonia, while 14% develop severe symptoms, dyspnea, hypoxia, or more than 50% lung involvement on imaging, and 5% develop critical symptoms, respiratory failure, shock, or multi-organ dysfunction. Older people are at a higher risk of developing severe symptoms. Some people continue to experience a range of effects, long COVID, for months after recovery, and damage to organs has been observed. Multi-year studies are underway to further investigate the long-term effects of the disease. COVID-19 transmits when people breathe in air contaminated by droplets and small airborne particles containing the virus. The risk of breathing these in is highest when people are in close proximity, but they can be inhaled over longer distances, particularly indoors. Transmission can also occur if splashed or sprayed with contaminated fluids in the eyes, nose or mouth, and, rarely, via contaminated surfaces. People remain contagious for up to 20 days, and can spread the virus even if they do not develop symptoms. Several COVID-19 testing methods have been developed to diagnose the disease. The standard diagnostic method is by detection of the virus's nucleic acid by real-time reverse transcription polymerase chain reaction (RRT-PCR), transcription-mediated amplification (TMA), or by reverse transcription loop-mediated isothermal amplification (RT-LAMP), from a nasopharyngeal swab. Several COVID-19 vaccines have been approved and distributed in various countries, which have initiated mass vaccination campaigns. Other preventive measures include physical or social distancing, quarantining, ventilation of indoor spaces, covering coughs and sneezes, hand washing, and keeping unwashed hands away from the face. The use of face masks or coverings has been recommended in public settings to minimize the risk of transmission. While work is underway to develop drugs that inhibit the virus, the primary treatment is symptomatic. Management involves the treatment of symptoms, supportive care, isolation, and experimental measures. Nomenclature. During the initial outbreak in Wuhan, the virus and disease were commonly referred to as coronavirus and Wuhan coronavirus, with the disease sometimes called Wuhan pneumonia. In the past, many diseases have been named after geographical locations, such as the Spanish flu, Middle East respiratory syndrome, and Zika virus. In January 2020, the World Health Organization (WHO) recommended 2019 nCoV and 2019 nCoV acute respiratory disease as interim names for the virus and disease per 2015 guidance and international guidelines against using geographical locations or groups of people in disease and virus names to prevent social stigma. The official names COVID-19 and SARS-CoV-2 were issued by the WHO on the 11th of February 2020. The Director General, Tedros Adhanom, explained that CO stands for corona, VI for virus, D for disease, and 19 for 2019, the year in which the outbreak was first identified. The WHO additionally uses the COVID-19 virus, and the virus responsible for COVID-19, in public communications. Signs and symptoms. Cause. COVID-19 is caused by infection with a strain of coronavirus known as severe acute respiratory syndrome coronavirus 2. SARS-CoV-2. Transmission. Virology. Severe acute respiratory syndrome coronavirus 2. SARS-CoV-2 is a novel severe acute respiratory syndrome coronavirus. It was first isolated from 3 people with pneumonia connected to the cluster of acute respiratory illness cases in Wuhan. All structural features of the novel SARS-CoV-2 virus particle occur in related coronaviruses in nature. Outside the human body, the virus is destroyed by household soap, which bursts its protective bubble. SARS-CoV-2 is closely related to the original SARS-CoV. It is thought to have an animal, zoonotic, origin. Genetic analysis has revealed that the coronavirus genetically clusters with the genus Beta coronavirus in subgenus Sarbecovirus, lineage B, together with 2 bat-derived strains. It is 96% identical at the whole genome level to other bat coronavirus samples. BAT-CoV-RATG13. The structural proteins of SARS-CoV-2 include membrane glycoprotein, M, envelope protein, E, nucleocapsid protein, N, and the spike protein, S. The M protein of SARS-CoV-2 is about 98% similar to the M protein of bat SARS-CoV. Maintains around 98% homology with pangolin SARS-CoV, and has 90% homology with the M protein of SARS-CoV. Whereas, the similarity is only around 38% with the M protein of MERS-CoV. SARS-CoV-2 variants. The many thousands of SARS-CoV-2 variants are grouped into either clades or lineages. The WHO, in collaboration with partners, expert networks, national authorities, institutions and researchers, have established nomenclature systems for naming and tracking SARS-CoV-2 genetic lineages by GISAID, Next Strain and Pango. At the present time, the expert group convened by WHO has recommended the labeling of variants using letters of the Greek alphabet. For example, alpha, beta, delta, and gamma, giving the justification that they will be easier and more practical to discuss by non-scientific audiences. Next Strain divides the variants into 5 clades: 19A, 19B, 20A, 20B, and 20C, while GISAID divides them into 7 L, O, V, S, G, GH, and GR. The Pango tool groups variants into lineages, with many circulating lineages being classed under the B1 lineage. Several notable variants of SARS-CoV-2 emerged throughout 2020. Cluster 5 emerged among minks and mink farmers in Denmark. After strict quarantines and a mink euthanasia campaign, the cluster was assessed to no longer be circulating among humans in Denmark as of 1 February 2021. As of December 2021, there are 5 dominant variants of SARS-CoV-2 spreading among global populations. The Alpha variant, B.1.1.7. Formerly called the UK variant. First found in London and Kent. The Beta variant. B.1.351. Formerly called the South Africa variant. The Gamma variant. P.1. Formerly called the Brazil variant. The Delta variant. B.1.617.2. Formerly called the India variant. And the Omicron variant. B.1.1.529. Which had spread to 57 countries as of 7 December. Pathophysiology. The SARS-CoV-2 virus can infect a wide range of cells and systems of the body. COVID-19 is most known for affecting the upper respiratory tract, sinuses, nose, and throat, and the lower respiratory tract, windpipe and lungs. The lungs are the organs most affected by COVID-19 because the virus accesses host cells via the receptor for the enzyme angiotensin-converting enzyme 2, ACE2, which is most abundant on the surface of type 2 alveolar cells of the lungs. The virus uses a special surface glycoprotein called a spike to connect to the ACE2 receptor and enter the host cell respiratory tract. Following viral entry, COVID-19 infects the ciliated epithelium of the nasopharynx and upper airways. Nervous system. One common symptom, loss of smell, results from infection of the support cells of the olfactory epithelium, with subsequent damage to the olfactory neurons. The involvement of both the central and peripheral nervous system in COVID-19 has been reported in many medical publications. It is clear that many people with COVID-19 exhibit neurological or mental health issues. The virus is not detected in the CNS of the majority of COVID-19 patients with neurological issues. However, SARS-CoV-2 has been detected at low levels in the brains of those who have died from COVID-19. But these results need to be confirmed. While virus has been detected in cerebrospinal fluid of autopsies, the exact mechanism by which it invades the CNS remains unclear and may first involve invasion of peripheral nerves given the low levels of ACE2 in the brain. The virus may also enter the bloodstream from the lungs and cross the blood-brain barrier to gain access to the CNS, possibly within an infected white blood cell. Research conducted when alpha was the dominant variant has suggested COVID-19 may cause brain damage. It is currently unknown if such damage is temporary or permanent, and whether Omicron has similar effects. Observed individuals infected with COVID-19, most with mild cases, experienced an additional 0.2% to 2% of brain tissue lost in regions of the brain connected to the sense of smell compared with uninfected individuals. And the overall effect on the brain was equivalent on average to at least 1 extra year of normal aging. Infected individuals also scored lower on several cognitive tests. All effects were more pronounced among older ages. Gastrointestinal tract. The virus also affects gastrointestinal organs as ACE2 is abundantly expressed in the glandular cells of gastric, duodenal and rectal epithelium as well as endothelial cells and enterocytes of the small intestine. Cardiovascular system. The virus can cause acute myocardial injury and chronic damage to the cardiovascular system. An acute cardiac injury was found in 12% of infected people admitted to the hospital in Wuhan, China, and is more frequent in severe disease. Rates of cardiovascular symptoms are high, owing to the systemic inflammatory response and immune system disorders during disease progression. but acute myocardial injuries may also be related to ACE2 receptors in the heart. ACE2 receptors are highly expressed in the heart and are involved in heart function. A high incidence of thrombosis and venous thromboembolism have been found in people transferred to intensive care units (ICU) with COVID-19 infections, and may be related to poor prognosis, blood vessel dysfunction and clot formation, as suggested by high D-dimer levels caused by blood clots, are thought to play a significant role in mortality. Incidences of clots leading to pulmonary embolisms and ischemic events within the brain have been noted as complications leading to death in people infected with SARS-CoV-2. Infection appears to set off a chain of vasoconstrictive responses within the body. Constriction of blood vessels within the pulmonary circulation has also been posited as a mechanism in which oxygenation decreases alongside the presentation of viral pneumonia. Furthermore, microvascular arterioles and capillaries blood vessel damage has been reported in a small number of tissue samples of the brains, without detected SARS-CoV-2 and the olfactory bulbs from those who have died from COVID-19. COVID-19 was also found to cause substantial, including morphological and mechanical, changes to blood cells, such as increased sizes, sometimes persisting for months after hospital discharge. Other organs. Another common cause of death is complications related to the kidneys. Early reports show that up to 30% of hospitalized patients both in China and in New York have experienced some injury to their kidneys, including some persons with no previous kidney problems. Autopsies of people who died of COVID-19 have found diffuse alveolar damage and lymphocyte-containing inflammatory infiltrates within the lung. Immunopathology. Although SARS-CoV-2 has a tropism for ACE2 expressing epithelial cells of the respiratory tract, people with severe COVID-19 have symptoms of systemic hyperinflammation. Clinical laboratory findings of elevated EL2, EL7, EL6, granulocyte macrophage colony stimulating factor, GM-CSF, interferon gamma-induced protein 10, IP10, monocyte chemoattractant protein 1, MCP1, macrophage inflammatory protein 1 alpha, MIP1 alpha, and tumor necrosis factor, TNF alpha, indicative of cytokine release syndrome, CRS, suggest an underlying immunopathology. Additionally, people with COVID-19 and acute respiratory distress syndrome, ARDS, have classical serum biomarkers of CRS, including elevated C-reactive protein, CRP, lactate dehydrogenase, LDH, D-dimer, and ferritin. Systemic inflammation results in vasodilation, allowing inflammatory lymphocytic and monocytic infiltration of the lung and the heart. In particular, pathogenic GM-CSF secreting T cells were shown to correlate with the recruitment of inflammatory IL-6 secreting monocytes and severe lung pathology in people with COVID-19. Lymphocytic infiltrates have also been reported at autopsy. Viral and host factors. Virus proteins. Multiple viral and host factors affect the pathogenesis of the virus. The S protein, otherwise known as the spike protein, is the viral component that attaches to the host receptor via the ACE2 receptors. It includes two subunits, S1 and S2. S1 determines the virus host range and cellular tropism via the receptor binding domain. S2 mediates the membrane fusion of the virus to its potential cell host via the H1 and HR2, which are heptad repeat regions. Studies have shown that S1 domain-induced IgG and IgA antibody levels at a much higher capacity. It is the focus spike proteins expression that are involved in many effective COVID-19 vaccines. The M protein is the viral protein responsible for the transmembrane transport of nutrients. It is the cause of the bud release and the formation of the viral envelope. The N and E protein are accessory proteins that interfere with the host's immune response. Host factors. Human angiotensin converting enzyme 2, HACE2, is the host factor that SARS-CoV-2 virus targets, causing COVID-19. Theoretically, the usage of angiotensin receptor blockers, ARB, and ACE inhibitors upregulating ACE2 expression might increase morbidity with COVID-19. Though animal data suggests some potential protective effect of ARB, however, no clinical studies have proven susceptibility or outcomes. Until further data is available, guidelines and recommendations for hypertensive patients remain. The effect of the virus on ACE2 cell surfaces leads to leukocytic infiltration, increased blood vessel permeability, alveolar wall permeability, as well as decreased secretion of lung surfactants. These effects cause the majority of the respiratory symptoms. However, the aggravation of local inflammation causes a cytokine storm, eventually leading to a systemic inflammatory response syndrome among healthy adults not exposed to SARS-CoV-2. About 35% have CD4 plus T cells that recognize the SARS-CoV-2 S protein, particularly the S2 subunit, and about 50% react to other proteins of the virus, suggesting cross-reactivity from previous common colds caused by other coronaviruses. It is unknown whether different persons use similar antibody genes in response to COVID-19. Host cytokine response. The severity of the inflammation can be attributed to the severity of what is known as the cytokine storm. Levels of interleukin-1b, interferon gamma, interferon-inducible protein 10, and monocyte chemoattractant protein 1 were all associated with COVID-19 disease severity. Treatment has been proposed to combat the cytokine storm, as it remains to be one of the leading causes of morbidity and mortality in COVID-19 disease. A cytokine storm is due to an acute hyperinflammatory response that is responsible for clinical illness in an array of diseases, but in COVID-19, it is related to worse prognosis and increased fatality. The storm causes acute respiratory distress syndrome, blood clotting events such as strokes, myocardial infarction, encephalitis, acute kidney injury, and vasculitis. The production of IL-1, IL-2, IL-6, TNF-alpha, and interferon gamma, all crucial components of normal immune responses, inadvertently become the causes of a cytokine storm.